Some people feel that private equity really focuses on, generating short-term profits, and so there are concerns. But again, I think this represents an interesting development.
The fact that some of these countries have a more, quote, socialistic system of medicine, do you think that plays a role, or is that a red herring of some sort?
Well, what I can tell you is, it is true that the U.S. is really the only high-income country without universal health care, raised by the definition of the World Health Organization. The playbook doesn't necessarily only call for the government to be involved in both financing and delivery to achieve universal health care. Other countries have achieved it in other ways.
Hello, and welcome to the International Business Today, IBT podcast. My guest today is Professor Gary Young, Professor of Strategic Management and Healthcare Systems in the International Business and Strategy Group here at the mckim School of Business. He's also the Director of Northeastern Center for Health Policy and Healthcare Research. He also has a faculty appointment in the Bouvet College of Health Sciences at Northeastern. In addition to his training in business, he's an attorney, and he's worked for several federal agencies, including the Department of Health and Human Services and the Department of Justice. And he's also served as a healthcare consultant for the Lewin Group before joining academia. He's been awarded numerous grants to research healthcare issues. He's published nearly 150 academic articles in healthcare and management journals, and he co-edited a book, The Healthcare Professional Workforce, Understanding Human Capital in a Changing Industry, which was published by Oxford University Press. Welcome, Gary.
Robbie,
Still wonderful to have you on this panel, on this podcast, and to join us at IBT. As you all know, International Business Today is a podcast series where we talk about current issues that are relevant to managers and practitioners. This is a very interesting time for healthcare right now, in the U.S. and globally. So, as you see it, what are some of the key developments affecting healthcare here and globally?
Yeah, Ravi, a lot of major developments going on. Certainly one is payment. So the country is really trying to pivot away from the traditional payment approach, which was fee-for-service, where we paid providers, for each service they delivered. Really regardless of performance based on quality and efficiency, and really trying to move our payment systems to focus on value. So we refer to them as value-based payment, or also sometimes it travels under the banner of pay for performance, but where we're trying to pay providers in ways that are very much linked to explicit metrics for quality and also for efficiency. And, the idea is that we're really trying to hold providers accountable for the services they deliver and not paying in such a piecemeal fashion. The other consideration there also is that in some cases we're paying providers a fixed amount of money in advance, a budget, if you will, where rather than paying them again for each service they deliver, we give them a fixed amount of money to take responsibility for a defined population, and also adding to that certain performance metrics for which they can receive additional money if they achieve those metrics. So really trying to change in a very substantial way our payment systems. In addition to that, of course, we have very interesting development. We have the entry of retail companies into healthcare. So, of course, we're talking about Amazon, we're talking about Walmart, Target, Dollar General. And, these retail titans want in on healthcare. These retail titans are at the gate and they want in on healthcare, or at least so it seems. And this really represents a very significant development in healthcare. The U.S. healthcare industry has much to be proud of. We have world-class facilities, highly trained healthcare professionals, life-saving medicines and technologies. But there are certain deficits, certain gaps in our healthcare system as well. When it comes to affordability, when it comes to convenience, when it comes to accessibility, our performance has often lagged. And these retail titans they're coming in and they see new opportunities to deliver healthcare in a way that is, in fact, more convenient, more accessible, and more affordable. And we will see what happens, but they're coming in trying to find new ways of delivering healthcare that can address some of those deficits. I guess another development would be private equity. So this is a relatively new development, but we have private equity firms now also entering healthcare, buying hospitals, acquiring physician practices, nursing homes. They're also coming in and seeing some of those deficits that I mentioned. And they feel that with investment in technology, offering in some cases what they believe is superior management, they can also address these deficits and improve the healthcare delivery that we all want to have here in the U.S. There's some controversies there because some people feel that private equity really focuses on generating short-term profits, and so there are concerns. But again, I think this represents an interesting development. And I guess one other important development is that as a system, we're also trying to shift away from a focus, really an exclusive focus on treatment, to one that really, where we start to really put more emphasis on prevention, population health, addressing the so-called social determinants of health, really trying to keep us healthier. And some of that goes back to what I mentioned before in terms of changing payment systems to focus more on value and using explicit quality metrics as part of the reimbursement or payment formula. But really, we are also trying to pivot as a nation away from a system that really emphasizes almost exclusively treatment and trying to, really put more emphasis on prevention, population health, disease prevention.
Yeah, I believe Medicare to some extent is a driver of this approach to capitation,
Yes.
where they say we'll pay you to take care of somebody X amount for a year, and then next year you come back and let's see if you get the contract again.
Right. So Medicare has rolled out payment models that do use budgets or capitation, as sometimes they're referred to, where healthcare providers organize into what's known as accountable care organizations and then contract with Medicare to provide services to Medicare beneficiaries under a sort of a budget system, also one that includes those quality metrics that I mentioned before. And there is also on the private sector side, we see private health plans adopting models that are somewhat similar to Medicare. So again, this really represents an important shift in the way that we are paying healthcare providers. I will say it is going slowly. So this is not something, we're not turning on a dime here. It's moving very slowly, but also steadily. And the idea is that eventually we will move away from that sort of fee-for-service system that has so much defined the way we pay healthcare providers in the past.
Right. Now, it sounds to me that these kinds of changes, retail and private equity, and trying to pay capitation for a group of people, means some emphasis on scale economies, which in turn means concentration, because typically scale economies come from size. So how do you see this degree of M&A occurring? Fewer owners of big hospital chains or fewer private practices, and instead physician care organizations being bought out by private equity, for example. So how do you see this concentration developing, and how might it affect healthcare?
Well, you're absolutely right. So there is certainly a movement toward bigger and more concentration, scalability. And yes, that is certainly raising concerns with antitrust enforcement agencies. And, the Biden administration is taking a more aggressive stance here. And in fact, they've recently sort of scrapped the antitrust enforcement guidance that was in place for about 30 years here in the U.S. that will give them more latitude to pursue enforcement on antitrust basis with respect to the healthcare industry. There was a time when we had thousands of hospitals in this country that were independent hospitals. Today, about 2/3 of all U.S. hospitals are parts of systems. And many of those hospitals are located in the same markets, which of course gives those systems enhanced negotiating leverage with health plans. So that raises concerns. Also, we are building out, as you said, some of these larger healthcare delivery systems. We are now seeing a very substantial movement for physicians away from independent practice to where they are now becoming under hospital ownership, often through some type of employment arrangement. So we're seeing this kind of integration between hospitals and physicians that really changes sort of the contours of the U.S. healthcare industry, because that really was a sort of a cornerstone feature in this country, where hospitals and physicians were under separate organizational arrangements. And today we're bringing them together. For some health policy experts, this is long overdue. They believe that we'll see better coordination of care by bringing hospitals and physicians together. For others, there's concerns. There's some evidence that hospital-physician integration is leading to higher prices for hospital and physician services. There are also studies addressing the concern that when you place physicians under hospital ownership, it will lead to more aggressive referral patterns on the part of physicians for more hospital-based services. So members of my research team have done several studies on this topic, and we do find that when physicians transition from independent practice to hospital-based arrangements, they do become more aggressive in making referrals for patients to hospital-based services like diagnostic imaging and other types of advanced diagnostic services that are hospital-based. Now, here again, some might say, well, is that perhaps providing better access, better timely services? Others worry about whether, in fact, what we're really doing is generating more inappropriate care, more inappropriate services that are stoking up higher prices and leading to higher healthcare spending, which, of course, is a concern in this country. Right. So the idea of concentration, scalability, building out bigger systems is certainly a concern. Again, some are optimistic that, in fact, it can lead to ultimately more efficient care and perhaps care that is of higher quality, better coordination of service delivery. But, we're trying to watch this very closely and sort of get a sense of sort of where this is going to lead.
Mm-hmm. Now, you mentioned this growing emphasis on value-based healthcare. Is this a global phenomenon? In other words, are other healthcare systems in other countries also doing this? And is there a possibility for learning from one another?
Certainly, high-income countries are, like the U.S., struggling with increased healthcare spending. Now, of course, we are at the top of the heap by far, but other countries are certainly struggling with rising healthcare costs as well, and are also trying to get a better sense of value. What kinds of services really add clinical value for patients, and what kinds of services, where the value is small or really non-existent, are we, paying for care that really isn't going to contribute much to patient health status. And so, we worry about certain services like diagnostic imaging, which may be done in some cases where there's very little clinical value, certain medications that may add very little clinical value. So certainly for countries that are high income, like the U.S., they're also trying to think through ways of trying to provide care that is more high value, trying to recalibrate payment approaches like the U.S. to put more emphasis on care that's of high value. I think we are trying to learn from each other. And certainly the UK, like the U.S., over the last 25 years has invested very heavily in what we might call value-based payment or pay for performance. I think we're trying to learn from each other. And we both recognize some of the errors that we've made. So I think that there is that type of learning. Lower income countries are not so much focused right now on thinking through value-based payment. Some of the low income countries are still trying to think through about how to expand health insurance to their population, how to build their primary care delivery infrastructure. So again, members of my team, we were working with the Egyptian government on what is a very ambitious and bold rollout of an initiative to expand health insurance to its population, and also to invest more in primary care delivery. There are, some of these lower income countries have a lot of challenges in doing this, but I think, the value-based payment approach is sort of another step. Once they are able to address some of those other issues, then they're going to think more about how to, revise payment approaches to achieve value. But I think that's right now more of a concern for higher income countries that may already have universal health care.
Yeah, because I'm recalling one of our colleagues, Professor Ramamurthy, has written about healthcare innovation in emerging markets. And his premises is that because their overall cost structure is lower, they can innovate and take advantage of that low-cost structure to be able to provide healthcare delivery that's more affordable. And he specifically talks about cataract surgery and about how they've reduced the time to do so. So are those the kinds of challenges that you see healthcare facing, but with some innovative new solutions coming, particularly in countries like Egypt or India or other emerging markets?
Yeah, well, I think certainly there are opportunities for the U.S. to learn from how care is sometimes provided in these countries. I think, yes, we have certain, over time, we've built in certain constraints to those systems such that it's not always easy for us to innovate quite the way we would like to. Sometimes those constraints are in the form of payment. Sometimes those constraints are in the form of some of our institutional arrangements. So in a sense, yes, sometimes countries that are still in stages where they're trying to invest in delivery infrastructure have somewhat more degrees of freedom, if you will, to try to do things in ways that ultimately, if you had to start all over in the U.S., make a lot more sense.
Gary, there is, I think, a broad realization that healthcare is something that is inelastic. You have to have it when you need it, either for prevention or for disease control. And there are systems around the world, since we're talking about international healthcare, that are more socialistic in orientation. So what is your take on the relative ability to offer healthcare widely, given constraints of resources and affordability and outcomes?
Well, Ravi, I think the U.S. is the only high-income country that does not have universal health care, at least by the definition of the World Health Organization. We've made great strides in that direction since the passage of the Affordable Care Act in 2010. We've been able to cut the size of the uninsured population by about half. But still, at any one point in time in the U.S., about 10% of our citizens are uninsured. So, that remains an important, quest here in the U.S. Now, other high-income countries, some of them do have systems that are both government financed and where delivery is largely also under the auspices of the government. But other countries have been able to achieve universal health care with decidedly a greater mix in terms of private and public sector involvement. So I don't think there's necessarily one playbook for achieving universal health, but certainly we've not been able to achieve it here in the U.S. There are certain cultural considerations here, I think, in the U.S. about how we want to move forward. Debates about universal health care have gone back many, many decades here in the U.S. And so we've never really been able to land on quite the right formula. We have a certain sense here in the U.S. of maybe more individual responsibility, where in other high-income countries there's more of a sense of community participation in healthcare. So I think that's probably been a bit of a challenge. There's been concerns here in the U.S. about a certain skepticism, if you will, about the government getting too involved in our healthcare, and that has also been something that has created resistance to moving forward with universal healthcare. So I think it's an important question that we're still trying to think through here in the U.S. But it doesn't, when we talk about universal health, I think sometimes there's a sense of, well, that means, the government is running the entire system. And that is perhaps largely true in some countries that have achieved universal health care, but not in all. Other countries have been able to achieve universal health care through, a mix of both private and public sector involvement. And it'll be interesting to see how we move forward and whether we can continue to sort of close the gap here, reduce the size of our uninsured population. Again, we have made great strides over the last 10 years, but 10% remain uninsured at any one time. So.
Mm-hmm. I think you used the word quest. I think that captures it nicely, that it is a quest. Most people feel, I think, that it would be good to offer healthcare to everyone. The issue is the means. How do we get there, right? So what are some of the other big changes that you see, the future of healthcare over the next 5 to 10 years, beyond this drive to figure out outcomes-based care and universal care?
Well, as I mentioned, we're going to continue, I think, to pivot away from fee-for-service to value-based care. I think that's, something that's going to continue to take some time, but I think we're going to continue to move in that direction. The U.S., as I said, we don't have universal health care, but we are a very expensive healthcare system. We are the most expensive in the world.
Mm-hmm.
I'm sure you've seen some of the statistics. We're approaching 20% healthcare spending for GDP. But basically 20 cents of every dollar, or close to every 20 cents of every dollar in this country is going to healthcare. Spend about $14,000 per person.
Mm.
And, if you're purchasing a health insurance for a family today, you're talking about maybe $24,000.
In premiums.
Yes. Okay. Now, many people are fortunate and their employer is covering some portion of that. But, it's expensive. And so we're trying to sort of figure that out. At the same time, while we have the most expensive system, when we think about it in terms of a return on investment, disappointing, because actually when we talk about our system performance relative to the performance of other high-income countries, we don't stack up so well. Okay, so even though we spend dramatically more, when it comes to life expectancy, infant mortality, avoidable deaths, and those are deaths that could be avoided by better public health initiatives or by more effective primary care. On those kinds of metrics, we don't do well. In fact, we're often at the very bottom when you compare us to high-income countries. So we don't do well, in many respects, given the amount of money we spend on our healthcare system. So we've got to figure out better ways. And again, moving to value-based care, I think, will continue, maybe slowly, but it will continue. Certainly, we want to think about how we can continue to invest in better prevention, population health, which could help us, improve on some of those metrics that I just mentioned. We also we have to see what these retail titans can bring to us, okay? Because that represents, as I said, a very significant development in our system. To see, our system has always been really characterized by these traditional providers that we're all familiar with: hospitals, physicians, nursing homes. Now we have, as I said, we have got the Amazons and the Walmarts and the Targets. They're coming in. They believe they have new ideas. They believe they can address some of the deficits that I've already mentioned. But we've got to see and see what they can offer. So I think that's an important consideration for the future of our system. I think also our system has been decidedly one that has emphasized nonprofit ownership of healthcare providers, in addition to these retail companies. As I said, we've also got private equity coming in. Investor ownership is not all that new to healthcare. We've seen investor ownership in the hospital sector now going back to the late 1960s. But we're seeing it now in a more substantial way. And again, how is that going to shape the future of healthcare delivery? Again, some have serious concerns, real worries. Other people think, well, maybe we need some new ideas because, again, as I mentioned, we don't stack up that well against high-income countries despite the huge amounts of money that we spend on healthcare. So some people think, we need some new thinking, we need some new ideas from organizations, from individuals that have not been part of the healthcare fabric for many decades. So I think those are going to, present some interesting considerations. Again, the quest to achieve universal healthcare. So I think we have some very interesting developments that may shape the future of healthcare delivery in the U.S. And I think it's going to be fascinating to sort of watch how this plays out over the next 5 to 10 years.
This has been a great conversation, Gary. Really, I think very useful. And I hope our audience has enjoyed this. And I wanted to say that if you've enjoyed this podcast episode, please do subscribe to our International Business Today podcast series. We've released around 30 episodes, and we're constantly recording and releasing new episodes. We would be delighted to hear your comments and suggestions, particularly for new ideas for episodes. And this is Professor Ravi Sarathi. I'm my guest, Professor Gary Young. Thank you all for listening to us, and see you again soon on another podcast.